All right, welcome everyone, and thank you for joining us today for this lunchtime panel um, entitled Amplifying Unheard Voices, Understanding and Ameliorating Medical Mistrust Among Black Communities. And I am here today with two lovely physician experts. First, my name is Dr. Tyeese Gaines. I'm an emergency medicine physician. I also work in insurance medicine as well as lifestyle medicine. And my passion in healthcare has always been working with vulnerable populations and being able to decrease healthcare costs associated with their care, as well as increasing their overall health and wellness. Um, and I have with me today Dr. Nailah Cooper, as well as Dr. Avian Tisdale, and I will let them tell you a little bit about themselves before we get started. Dr. Cooper, you want to go first?
I sure will. Thank you all for having me. So I'm Dr. Nailah Cooper, and I'm a pediatrician, and I've been practicing for over 7 years in a local outpatient clinic here in Phoenix, Arizona, that primarily focuses on serving lower socioeconomic groups and disadvantaged populations here in the Metro Phoenix area. But my story is a little bit different in that I'd like to add that I actually navigated the whole healthcare system as a single mom. So I have 3 young children that I had to juggle between going to undergrad classes, medical school, and residency as a single mom. So my journey and my expertise comes a little bit more from experience and actually being a consumer of the healthcare world. So I'm looking forward to talking a little bit about some of those experiences and how I've been using them in my day-to-day life as a pediatrician.
Thank you.
Hi there. Good afternoon now, everyone. I'm Dr. Avian Tisdale, and I'm also a pediatrician. It's wonderful to be here with both of you and everyone that's here in the audience. I worked as a hospitalist as a pediatrician, so I've never actually taken care of well children, really always kids who were sick in the emergency department or in the hospital. And so that is really where I love to be. I like situations where I can turn something that is really chaotic into something that looks orderly and makes sense to people. And it's also really fulfilling to me as a doctor for someone to be really sick and then to see all of that tension and anxiety melt away from parents as they get better. I really enjoy that. So I did that for many years, decided that I needed to understand the business of medicine better. That's part of the reason I'm here. I went back to business school to earn my MBA, like many doctors have. Ultimately, this year I decided to open my own micro practice, Dr. Honeymom, which, by the way, is all of my titles: wife, mom, pediatrician, but really wanted to start a very unique business model, use the skills that I learned. And I also wanted to continue to connect with the community I live in, not from Texas. So I joined the board of Houston Angels. It's a board that really supports families and children that are in foster care. So I interface with kids in my own practice. I see kids in urgent care, and I'm also a consultant. So I have multiple interactions with people every day who question what our expertise is and how they can apply it to their lives. So I'm here to really just continue the conversation.
Thank you. And thank you both again for being here. Just a reminder that this event today is hosted by the Center for the Business of Health, as well as the MBA Healthcare Club and the Black Business Student Association. So thank you to all of you guys for having us as well. Another quick thing, if you guys have questions for us as we're going through the question and answer process, feel free to drop them in the chat. You don't necessarily have to wait until the end if there's questions in the chat that are timely and relevant to what we're talking about. If I can keep up with the chat, I will try to grab some of them and ask our panelists. If not, at the end or in the center, and then also at the end, I'll pause a couple times to see if there's any questions, if you want to raise your hand or just drop them in the chat. So again, we're just here to have a conversation. So if something comes to mind, don't be shy, drop it in the chat and we will do our best to answer them. So we're talking about this topic, obviously, for those that are looking to become healthcare leaders. I think it's becoming more and more clear that in order to take care of patients, we have to take care of the whole patient. And sometimes that means being able to address the things that are going to keep them rather away from us. And sometimes that is rooted in either current or historical things that make them a little apprehensive. I think we've seen it kind of front and center as well within the conversation of vaccine hesitancy, right? We've heard that term a lot in the news with folks that were worried about getting the COVID vaccine. And I think that actually started to uncover, I think physicians who take care of patients of color kind of knew this was already there, or we already knew the history ourselves. But I think it was put on a bigger stage of, why are certain groups so afraid of getting this vaccine? Why are they so suspicious of what's going on? And then I think it started to uncover this is deeper than just, a little bit of conspiracy about this particular vaccine, that it was actually a skepticism and an uncertainty about how to navigate the system as a whole based on, prior acts or just history in and of itself. So I think that it's important for us to discuss. I'm glad we were asked to come and talk about it, because trust in healthcare is very important. And I think because it's not something that's directly measurable, sometimes we don't give it the weight that it deserves. But we do know when we've looked at some outcomes that a patient having trust in their healthcare provider, regardless of what the reason is, there's been different studies looking at different factors, it does affect the outcome. So I think that it is important for us to talk about the opposite, which is the mistrust, and where some of that comes, particularly in this case, talking about vulnerable populations, and especially some of the historical stuff within the Black community. So with that, I will open it up to our panelists to ask, in your experience, taking care of patients, having discussions with patients and their families, and your own experiences, where do you feel like this mistrust is coming from? And whoever wants to start first.
I'll take that first, Dr. Cooper, if that's okay with you. I think, Dr. Gaines, there are really three things I think historically that we need to consider, and it's really important. Now we start the conversation with this. When we really think about historically what African Americans experienced in the way of healthcare when we were introduced to this country, I think there are three things that always influence culture: language, diet, and medicine. And I think often when we talk about Black history, we sort of talk about it like it started here in the United States, but there was a lot of history and a lot of culture already present when we were on the African continent historically. And so that means we already had language, we already had a diet, and we had a specific way that we practiced and lived medicine. And so I think when you transplant people and then they are in an environment where they're completely unfamiliar with the language, and we see this even in our current practice, people who don't speak English, people who are not used to a Western diet, and people who are not accustomed to Western medicine really have a hard time getting themselves acclimated to the way we do things when they come here. And so I don't think that we are an exception to that. I think that's very historical. And then, as we discussed just before we got started, historically, medicine has weaponized itself against African Americans. And I think those two things together really build that culture of mistrust, not being familiar, and then also being the victims of predatory practice. And so I think whenever we're having conversations about where it came from, I think we need to have a little bit more discussion about what was going on before we were brought here, and then also what was done once we got here. And I think you brought up a good point about COVID. I know there were a lot of people who felt the uncertainty, including us, about what direction that would go in. But I think it also, again, put us in a very unique position where not only were we uncertain, but we did not trust the information, a lot of us, that we were getting. And so to me, I think that's really where it stems from.
And I too want to add to that as well, too, kind of piggybacking off what you said. I like how you went sort of to the beginning on where it began an issue here in the United States. And for me, I see it in a sort of a three-tier approach. We have our systematic issues that are addressing and introducing and producing mistrust for us as a system of African Americans and other minorities who are having to go into these healthcare arenas to receive care. And then additionally, there's the actual physical medical insults that have happened over the years, from the beginning of when you were just kind of alluding being here, the things that happened during slavery, after slavery, and unfortunately, even now, the things that happen with abortions and just different things when you're taken advantage of. So there's that actual physical insult that breeds the mistrust. And then finally, as we're moving forward, there's still that overt insult that happens to where it's you feel it, but you can't exactly name it, but everybody in the room feels it. So all of these different areas to where we're dealing with the systems, the actual physical insult, and the overt practices that are woven into the language of healthcare industry and our businesses and how we market, to where there's a lot of different avenues that are layered into our society on how we as African Americans and other minorities just are faced with issues and different things that breeds the mistrust for us. So it's very, very tiered in its approach.
Can I add just one thing that I just thought about as you were talking, Dr. Cooper? One thing that's also really important, because we're using the word history. So of course that always sounds and feels very dated. And I don't know what the experience is for the two of you, but to this day, practicing here in South Texas, there are families that I meet every day who tell me this is the first time they have seen a Black physician. This is 2022. And so I just want everyone who's here to think about, and I know that can be true for lots of people, not just Black folks, but I think it's important to understand how that influences your ability to communicate, to trust the information that you receive, to feel that your unique culture and questions and challenges are being taken into consideration. I, again, don't know what your experience is, but I have seen children who literally look at me like I'm more than I am, because it is the first time they've seen a physician who looks like them. And that always shocks me, because if they have not seen a Black physician, that means it's likely their parents have never seen a Black physician. And that just stuns me, almost speechless, that someone could be my age or older in the United States and still not feel represented. But it's important to point out that the three of us represent a very almost negligible statistic in terms of measuring how many physicians look like us. And so our patients notice that and feel that also.
Absolutely. So I do want to talk some more about kind of the present day, but I do just want to go back just for a sec and let us talk a little bit about some of the historical stuff. So I don't know if there's any of the historical examples that really speak to you guys that you want to bring up or talk about, that you feel maybe has had some of the biggest impact. I don't know if any of you guys want to jump in. If not, I'm happy to share some of mine as well.
I think one of the things that's always stood out to me as a pediatrician is the difference culturally. And I'm talking a lot about culture on purpose, because as we all know, as business owners or professionals, culture really predominates everything else that goes on in an organization. But I think that one of the things that's always stood out is the way that we raise children, the way that we are expected to care for them culturally can be very, very different from what the rest of the United States or the rest of the country historically has done. And I think that one of the mistakes that we often make in medicine is when we're trying to study African Americans, or when we've studied the African American family or patient in the past, it's sort of through the lens of disadvantage. And one of the things that really, really frustrates me about medical research is I think we've left data on the table where, when we're talking about the average African American family who's not disadvantaged, that's not uneducated, that does not have a low socioeconomic status, all of the studies that we see historically bring in information that really circles or centers around that. And I think there's a lot of data missing on what the average African American family looks like. And so often when I'm in the room with a family or I'm talking to a parent, it's a historical, cultural difference in the way that they perceive medicine and administering it to their children. And that same mistrust creeps in from what they would do with their own medical care and the questions they have for their children. So I think that often we deal with that same projection they dealt with the entire time they were growing up, not being represented, knowing at least peripherally about some of these weaponized practices and studies and projects that took place specifically in our communities, that comes up a lot in discussion, and you'd be surprised how many young people will decline care or not receive care because of it, but they're not really familiar with the study at all or exactly what happened. It's something that was passed on to them as sort of tribal knowledge, if you will. This happened, and so this is why you can't trust them, even Black doctors.
Absolutely. And I think that what's important about what you just said, and Dr. Cooper, I think you alluded to it too, is sometimes it's just a feeling, right? It's just a discomfort. And that's actually, so, some of the big historical things that we're referring to for those in the audience are like the Tuskegee experiment, which I can break down in a second. As an example, most people that have this level of what we'll call hesitancy or mistrust probably cannot quote for you exactly what happened in the Tuskegee experiment. They think that something was injected into them as opposed to what actually happened. They don't know what decade it was, but they're left with the feeling. The feeling is what has been passed down from generation to generation of, they want to experiment on us, so don't trust that. And so that's what I found the most interesting in a lot of the discussions that have popped up, even in my lay circle since the COVID vaccine popped up, is, well, where is that coming from? Oh, well, and they're citing kind of these studies, but then I said, well, do you know what actually happened in those studies? They actually don't. So it's just the feeling of, but we know something really bad happened. And so because we know that, don't trust this system. And that is what's passed down. It's not actually the factual, and I'm not saying that the facts were any better than, that they're positive at least, but that it's not even the actual facts. It's just this sentiment that's actually what's passed on from generation to generation. And so just to be complete, for you guys, so specifically with the Tuskegee experiment, it was not, and a big misnomer is that people were actually given something, and it wasn't. It was really that patients who had syphilis, the full title is actually pretty long, it's the Tuskegee Study of Untreated Syphilis in the Negro Male, and it went on from 1931 to 1972. So that's 40 years, guys. So, basically they allowed people who had a disease, who believed they were being treated for that disease, to not be treated, essentially, as the title states, and so that those researchers / physicians, if you call them that, could see what would actually happen to these men if, with the progression of disease over this 40-year period. So just imagine as a patient that you find out you have a disease. The doctor, maybe they tell you, maybe they don't tell you, but either way, they don't treat it. You think you're being treated and cared for. And then you find out maybe 20 years later, if you don't die before you find out, that you were never actually treated for what you trusted this physician to do, is to make you healthy. Now you may have spread that to your significant other, your spouse, who, they may have spread it to people, all the while you thought you were doing the right thing by going to the doctor and being treated. So just imagine, if you even did survive that, how does that make you feel? Now you have toe pain or belly pain or a headache. How are you going to feel about then going to the doctor? Are you going to believe that they're actually taking care of you? And, imagine if it's something else that is communicable and you could spread to someone. Am I now putting everybody else at risk because I can't even trust whether this doctor is or is not treating me? And I will point out, not everybody that was involved in the Tuskegee experiment, as far as on the healthcare side, were non-Black. There were nurses and physicians that were, where they were not, it was not all white. So again, where is safe? So he leaves the person and a community with this feeling of, well, who can we trust? How do you know? They had a white coat or they looked official. And then as other things happen, it kind of breeds that same feeling. So I just wanted to kind of give you guys that context. But Dr. Cooper, was there, I don't know if you wanted to add your kind of the things that stand out for you in history as well.
Yes. So there were two different things I wanted to kind of add. The first is how medicine was developed, and actually some of the subjects that were involved in the people that we revere today. So Dr. Marion Sims has been known in America as the father of gynecology for a while. And unfortunately, a lot of the gains that he's made in medicine have involved treatment or practices, I think is the better word, practices on young slave women, and to the point to where some of them were 16. And this involved him trying to come up with ways to repair some of the childbirth trauma that resulted from them giving birth in order to allow them to be able to be repaired to have more children, because this was a business, right? So Dr. Sims was instrumental in trying to help the slave masters to produce more products. So by him experimenting, by him developing these practices, he helped that generation. And the good thing is, yes, there did become different things that came out now, the ability to look into the woman's vaginal canal, the ability to be able to be revolutionary in treatments started from him, but it was the issue of we're dealing with people who didn't have the ability to consent. There was an unfortunate article that came out less than 10 years ago, I believe it was, 2006, the Journal of Medical Ethics, that sort of kind of painted this picture that said, well, he wrote that they did consent and that they did say it was okay, but really, can a 16-year-old, can a 17-year-old, number one, can they consent? Number two, if you're somebody's property, do you have the right and the understanding to say, okay, I can deny or accept this? And then they also mentioned in the article that what they were experiencing was like the lesser of the two evils. So even though his practices were inhumane, what they were dealing with was worse. So it's a very tricky area, but still it's like, that's not okay. And then even more today, one of the other things that I wanted to bring out that's a little less, I say toxic, or a little less maleficent, or yeah, that's the word I'll use, is the Henrietta Lack situation, to where this young lady was going in to seek treatment for her cancer. And while she was receiving treatment, she unknowingly was having her cells used for other purposes. Well, that's okay. She didn't really have an insult, but she was taking advantage of her. She wasn't compensated for these things. Neither was her family compensated. So these are two different examples to where we have actual physical harm, and then we have the harm of not replenishing or giving compensation for the gains that have been made on behalf of the person who was in this particular study. So I wanted to highlight those two different areas that are involved in our history. And then I also highlighted the article that was in the Journal of Medical Ethics on how, even though that was then, how the attitude of these particular things still is present today.
Absolutely. And what's interesting about, actually, with both of your examples, to go back to James Marion Sims, the interesting thing too there is that so in a lot of ways, especially with his procedures, in a lot of this, there's an overlying also of social unfairness. So it is an issue of medical mistrust, right? Or rooted in medical, I know there's a book called Medical Apartheid, right? But then there's also the social aspect of it. So the irony with the James Marion Sims practices is that in addition to all of this, in his notes, he wrote that, these procedures were very painful, as an example. And he would actually write, oh, that they didn't need the slaves didn't need pain meds. It wasn't, the procedures that he was doing were not very painful. They were fine. And he perfected his technique on them. But then in addition to allowing them to be able to procreate and make more children, which, you know, helped business, he also then took the technique that he perfected on the slaves and then basically marketed himself to perform it then on white women who could obviously compensate him for his services. But the irony is that they were all given anesthesia and pain meds for the same procedure, that he wrote in his notes that, oh, it's no big deal, these slaves, they don't need pain medicine. So it's like, you know, it's there's the advantage of doing this, but then there's also just the bias and the perception as well of, I don't, you know, well, they didn't need pain meds, but these women, oh, we need to give them pain meds. And sadly, even though it sounds kind of, you know, ridiculous, that has perpetuated to present day. There was actually a study with residents not that many years ago, and it showed that the residents actually felt that patients who were Black felt less pain than folks of other ethnicities and races. And there's been countless studies that show for long bone fractures, Black patients get fewer doses of pain meds, right? So this theme has, you know, even though you would say, oh my gosh, like who would do that? But it still perpetuates to present day, right? So I think, Dr. Tisdale, you mentioned some of the conversations that you've been having with patients in your office, but in general, like, how are you seeing this mistrust? If you can add, or Dr. Cooper, if you could share, how are you seeing this mistrust kind of occur? Either things that you're witnessing that's unjust, or just the conversations that you're having with patients that are now bringing some of this stuff to, you know, the 2000s, basically.
I think that the mistrust manifests itself as avoidance. And I think that we can all agree as physicians that the best treatment, of course, is prevention. But just as you just described, we talked about how Black people endured these sorts of things. And I'm so glad you brought up the study about the perception of pain that was done very recently, because these are still things that happen now. And so if someone thinks that they are not going to be treated fairly, if they think they're going to be in excessive pain, if they don't think that this person is going to help them, ultimately, they're just going to avoid seeing you. And as we know, that just makes people sicker. It results in poorer outcomes. We have less data studying people, women and men who look like us. We have even less data on children, African-American children with diseases that have plagued our community for generations. And so I think that it manifests itself as them not receiving medical care, which ultimately hurts us. A quick story that I think is important related to the pain point. As I'm sure Dr. Gaines, you've experienced, I had to provide procedural sedation often in the ER. When someone breaks a bone, they need a lot of pain medication to relax or not be conscious when it's being taken care of. And I had approximately, it was a school-aged child, African-American child, who her arm, I don't remember how she injured it, but it looked like the shape of an S. It looked very uncomfortable and she was in a lot of pain. Children are amazing. And the reason I'm a pediatrician is because they are extremely resilient. But the point is, the surgeon came in to see the child and really wanted to get started with the procedure before she had an IV, before she'd received any pain medication. This was fairly early in my career as a leader, in a leadership role. And I just felt so compelled. These poor parents seemed so concerned about their daughter. I don't think they really understood what was going on. But long story short, I had to put my body between the patient and the surgeon. And I ultimately said, you're just not going to touch her until she has pain medication. And I think that that happens a lot more often than people think. That's a really dramatic example, but there are others where I think this procedure is something that needs to be done in a separate place because pain control would not be adequate here. This is something that still goes on and is a huge issue with parents of African-American children in different settings. How well is their child's pain going to be controlled, especially when they're not there, which happens with parents. And so I've certainly experienced that as a physician. My children have had various procedures done over the years. And I think it's really important to remember that as physicians and as Black women, we're not only advocates for our own patients, but for ourselves and for our own families. These could very well be people that we know and love, or people who are seeking care. And I tell my family all the time, I try to be the same doctor that I expect you to see when you need care, even if I'm not around. And so I think that's really important.
Okay, and I also wanted to add a little bit to what you guys have been saying, and especially highlighting the avoidance part. I've talked to different men, mainly Black men in the community, who are hesitant to go to the doctor because of fear of bad news. But the unfortunate thing is that how we've been set up with our lifestyle, with stress, which I'll talk a little bit more about down the line, but we're living a life that is actually detrimental to our health. And so the longer you wait to go to the doctor, the more you're sort of filling up your cup with unhealthy things, whether it's lack of exercise, whether it's unhealthy eating habits, whether it's stress of the day to day, trying to provide for my family, trying to make sure that I'm where I'm supposed to be, avoiding, racism. All of those things are adding up in that cup. And by you avoiding going to your doctor, it's when you get there, it's sort of reaffirms that, oh, they only give bad news. But the unfortunate thing was that the bad news had been building up, but because you didn't trust that provider, and because you didn't trust that system, you in a sense shot yourself in the foot. So it's a very unfortunate sort of weighing situation that a lot of and I see it more with African American males, because they're the ones they're supposed to be the providers. I'm strong, I'm this, I don't ask for help because I've got it, and that's the way that unfortunately they're supposed to be. But no, it's you have to ask for help, but in asking for help, you got to trust that person. And a lot of the Black men that I've talked to, they don't. And then when they arrive, yep, see, I knew it. I had high blood pressure. There's that cancer. I have diabetes, and it's been lurking there the whole time, but you just avoided going. And it's something that could have been prevented, something that could have been addressed sooner, was not, because of the experiences, because of your lack of mistrust, and because of lack of knowledge. So it's a very unfortunate thing that as that information is either not sought or withheld through different avenues, it ends up being a poor outcome in the end. So it's very unfortunate.
Yeah, it's definitely a cycle that kind of begets itself, like you said, because the longer you wait, the more complicated things you need, the more you put yourself in a vulnerable position, right, where you then have to trust people, and then it kind of goes around. And it's interesting you mentioned, I think anecdotally we all see the same, those of us that practice, that it is the African American men compared to African American women. But I think some of that is also by nature that women in general across all cultures tend to hit the healthcare system, whether they want to or not, but they're not always doing it because of sick care, right? There's menstrual related things, there's pregnancy, right? So even if you were a relatively avoidant African American female with respect to the healthcare system, at some point you're probably going to have to intersect it. And it's not always a negative experience, right? Because the birth of a child, unless you have complications, is typically a positive thing, right? Whereas the men could literally go their whole lives, right? If they feel good, that's the big, oh, I feel okay, doc, I feel healthy, I'm good, I can run. And I'm like, that's great. That doesn't mean that you don't have something, brewing. They don't have as many mandatory things where they have to intersect the healthcare system the way that women tend to, and women tend to earlier in life. So women, we tend to intersect because, again, if you're having babies, you're typically younger, healthier, right? It's not like your first time is in your 60s. So there's whole men who don't see a doctor until they're literally almost Medicare age, right? So because they don't have anything along the way, if they feel okay, that requires them to truly intersect the healthcare system. Whereas women are, at least typically, if they have children, they tend to intersect healthier, younger, without such catastrophic things happening to them. So that's just the one thing I wanted to point out too about the gender difference. And I think the other important thing too, I think was Dr. Tisdale that mentioned the like the clinical trials. I think that's a huge thing. I started medical school over, can't believe it, over 20 years ago at this point. And I still remember when we finally figured out that the reason why blood pressure was not being controlled in certain African American patients, because we were giving them a medication that was not effective in African Americans, right? So just for you guys in the audience, what was happening is that we were treating African American patients for high blood pressure with beta blockers, so metoprolol, things like that, and they were not getting better. So we kept saying they're not taking their medication, they're not being compliant. Again, the immediate perception, right, was that they weren't taking their meds, not that the meds weren't working, because they were working in the other patients. And it took years for someone to finally look and see that maybe this class of medication just isn't working for this like genetic subset of people, i.e. African Americans, and maybe we needed to treat them with other medicines. And they switched to, calcium channel blockers for some of the patients, and miraculously their blood pressures are normal, right? And so these patients were telling the truth, they were taking the medicine were not effective. Likewise, there was a study maybe 6-7 years ago with breast cancer. They took out access to care, income, like everybody was equal, Black women, white women, and the white women were still faring better. With all the other variables being the same, they were responding to the treatment better. So it begs the question, since we already saw this, right, with high blood pressure medicines, is the issue that we don't have enough clinical trials where we can see these genetic differences? Because if it's happening with African Americans, it can happen with other populations as well. Maybe we need bigger, more diverse groups of patients to try the medications on, to test the medications with, to see is it more effective in one group over the other, instead of the initial typical doctor assumption, oh, they're just not taking their medication, right? I see Dr. Cooper smiling, because that's what people are quick to say about patients, rather than actually contemplate that maybe there's a difference. So but again, I mean, if we can't even get patients to come into the office because they're so scared, trying to have a conversation about letting them be a part of a clinical trial, like, it's almost an impossible discussion. So I'm just going to take a second and pull a couple of questions out of the chat. So the first question, Brian Adams posted, I have family members of the same belief. That was what back, Dr. Cooper, when you were talking about not, basically being avoiding, not wanting to come into the office. So the question to both of you guys is, how would you suggest talking to those family members that are avoiding the healthcare system, don't want to go in, don't trust that they're going to be treated well? How do you guys talk to them?
I think one of the first things that I always recommend is to go when you feel well to the physician. I think that one of the things we've learned historically in our culture is you don't need to go to the doctor until you're really, really sick or almost dead. And I actually think that the stereotypical strong Black woman has hurt us as women. I think that, being strong in some people's minds means they don't get sick. So I say to folks all the time, I know you're strong, I'm strong, strong people get sick too. And so I think what's really important is they're called well visits for a reason. I am not sick. My children are not sick. We go to our well visits. My husband is not sick. We go to our well visits every year. You can totally book an appointment with your doctor when you are not sick, just to talk about something you think could become a problem for you in the future. I think that is the most neutral, non-panicked, I know I don't need anything right now, so I don't expect to leave here with a prescription visit that you can have. Family medicine physicians are some of the most spectacular people on the planet, because they have these conversations with people every day. But they're not just there to take care of sick people, actually quite the opposite. They're there to keep you well. So I encourage people who are uncomfortable or who are nervous in a medical setting to go when they feel well, strictly to have a conversation. I found that my primary care colleagues really appreciate that. They recognize that everything's not going to change in one visit, that people will need to gain a rapport with them, and that there may be many conversations that they need to have before they ultimately come up with a plan that makes sense for everybody. But I always encourage my family, great, well, since you feel well now, it's the perfect time to go to the doctor. And I'm never not surprised by how surprised they are that that's a legitimate visit, even if they're not sick. You don't have to wait to see Dr. Gaines in the ER when it all comes crashing down. You can go and prevent it you can have these conversations and ask your questions from an expert when you're well.
Okay, and yeah, I'd like to add that to that as well. One of the avenues that I've encouraged a lot of the different people that I come in contact with is accompany, if you're a father, accompany your wife to your child's visit. And that's a great opportunity to maybe put in a question in an area to where you don't necessarily have to receive the information that's given. It's just an aside. It's something for information. It's not that you're seeking treatment. It's just helping you to learn how to communicate with the doctor and ask questions. Another thing that I would recommend is looking on your own to find out what is a screening. There's a lot of different screenings that come up at certain ages that you should be doing for checkpoints. So I would encourage young people to start having the conversation with their parents, and then for themselves to understand, okay, at what age do I need to do this? So in your 30s, you're starting to encounter different things that maybe you didn't encounter in your 20s. So understanding at certain age groups, there's certain things that you should be looking into. What is your sugar level? Is your blood pressure okay? Feel free to, when you're in Walmart or Walgreens and they have the little arm thing, put your arm in there and see what your blood pressure is, and compare that with what you know. And if you don't know, definitely reach out to a health professional and ask. That way you're looking into these things in a non-threatening environment, and you're practicing how to advocate for your own health. So that's the two things that I wanted to bring up as ways to sort of talk to your family members, talk to your parents, and then also for yourself on how to empower yourself to make sure that moving forward, you do not become a statistic.
Agreed. And if you are finding yourself significantly Googling medical questions about something, that may also be a trigger of, you know what, why don't I make an appointment and ask somebody who actually can give me a real answer? Because you can find a ton of stuff online. Some of it may be true, but not relevant to you. You may either falsely tell yourself, okay, I'm fine, I don't have any of those, and be wrong. Or the other way, you could completely freak yourself out, and then you end up in my ER at 2 a.m. because you've been Googling and you didn't need to do that. So I would say another trigger too is if you really have a lot of questions about something to the point where you're really, really deep diving and looking it up, and it's something you're concerned about with your own health, that's also a good question to just make an appointment to ask about. Those types of questions and visits are covered if you have an insurance. One other thing for you guys too, there was a question from Meyer Patel. I won't read the whole thing, but actually, I'm sorry, I skipped. Nicole Evans. And so basically, you already kind of touched about how to move past avoidance, but is there anything specific that you also say with respect to vaccines and boosters with respect to that avoidance that you throw in when you talk to folks?
One of the first things that I bring up is, because I sort of see this in the chat too, is what questions to ask and how to ask them, specifically about vaccines. Of course, as being pediatricians, it's a common topic. I think it's totally okay to tell us, I'm afraid of these things, I don't trust vaccines, or whatever it is you truly feel, you can just say it. It's amazing to me that people think there's something we have not heard as physicians or we've not seen. You would be surprised the things total strangers show us and tell us once that door closes. So it's highly unlikely you're going to invent a question we have not heard. It's okay to say, I don't trust doctors, but I'm trying to do better. That's why I'm here. We will hear that and receive that and meet you where you are. It's okay to say, I'm really afraid. I'm not afraid of doctors for myself, but I'm afraid to get care for my child. And here's why. People have different types of trauma in their history. And if you just tell us that, it's okay. It's a very vulnerable experience. Believe me, we all have stood in the space between life and death and when people are super, super sick. So it is okay to tell us exactly what you're thinking, exactly what your questions are, the way they are. Some people have no filter where this is concerned, so you can take some notes from them. But by all means, this is your only opportunity to tell us your side of it. We have plenty we can say and plenty we've learned and we think, but the more information that we have from you, the better. Ask your question exactly the way you have it. That's my advice. There isn't any special way. Just ask it.
And then two, I wanted to add that it's important to prepare your questions ahead of time when you go to the doctor and introduce the topic and say, I'm looking to do better. I'm looking to have a better health outcome, and then ask the questions. And then the other thing I wanted to add was that it's important to do research on the doctor that you're going to see. Talk to them about what you've seen on the reviews. And if you don't feel comfortable, doctors are just like any other product. If you don't like it, definitely find another one. This is your health that you're dealing with. So it is important to not only receive relevant and efficacious information, it's also important to feel that you trust that this person that you're going to has your best interests at heart. So feel free to shop around, but also come in with an open mind that, okay, all right, I need something, but at the same time, I'm going to keep seeking until I find that connection with how we talk and how we communicate, and then also with the information that you're giving me.
If it's okay, I actually will plug. I actually did a similar forum. It's a video on YouTube that I can share with you guys. There's two videos. It's all about patient advocacy stuff. So one of them was about how to pick a doctor, how to find a good doctor and pick them, and the other one was about how to make the most out of your visit. So Dr. Cooper, the point of preparing your questions ahead of time was one of those tips. So I can drop those in the chat in a second. The last thing I wanted to say about this particular topic. So Dr. Tisdale brings up a good point about just being vulnerable. And I will tell you another reason why that helps. So when I teach residents, a lot of time, I don't know why I feel like the cultural translator sometimes in the hospital. I don't know if you guys feel that way too. Someone will go see the patient, feel like a resident student, go, oh, like that person has such a bad attitude. They look like they don't want to be here. And I'm like, are they like, oh, they seem upset with me. Are they upset with you, or are they nervous, or are they afraid, right? Because fear looks different. Not everybody that's fearful comes in crying, right? Sometimes it's defensiveness, right? Sometimes it looks like anger. And so I encourage the medical students and the residents when I'm teaching them to, or even when I'm working with like PAs or nurse practitioners, and say, are you sure that's what it is? Like, you just met the person. They can't be that mad at you, right? What did you do? Why don't you ask them more questions? And inevitably, 100% of the time, there's something going on, either some social issue that they're bogged down by, or they are terrified of the fact that they even have to be in the office. So I'm saying that to piggyback on what Dr. Tisdale said, to say sometimes when you're not vocalizing that you're nervous about being there, it actually works against you, because you're obviously going to give off whatever that is, but it may not come off as fear, right? If it comes off as standoffish, I hate to say it, but physicians are people too. So when they go in a room and a patient's kind of standoffish, it can, with certain folks, affect how open they are with you, how much time they spend in that room, if they feel like they're offending you by being there. And I'm not saying that that's right, but it is a dynamic that I have seen, right? So if you're coming off as standoffish and they perceive it that way, they don't perceive it that you actually need even more tender loving care, then no one's going to be happy, right? They're not getting their job done. You're not getting your needs met. So I think that's even more of a reason to encourage folks to just call it what it is and just say, look, I am terrified to be here. I don't want to be here. I need you to go soft with me and go slow because I'm so friggin' nervous. Can you just do that for me? That, I mean, unless they're just like a sociopath, like that, it's gonna make them soften a little bit and warm and slow down. Because remember, doctors are also so busy right now. It will make them slow down and say, okay, I'm here, let me listen to you, as opposed to them misinterpreting your fear as they don't want to be here. They don't want to take the meds. Why are they asking me all these questions? Do they not trust me as a doctor? I hear this all the time. And I go, maybe, or maybe they're terrified of taking that medication and they don't understand what you're saying, right? And so that's work that we have to do in the profession on our end. But in the meantime, I think the best thing to do is to just call it out and be as transparent as you can from a very, vulnerable space, and ask them to give you what you need. If you need them to sit down and take their time, just ask them that, instead of, there being this miscommunication. Um, so back to really quick, the question from Amaya Patel. Dr. Tisdale, this is in reference to when you put yourself physically between yourself and the other doc. The question is about, is there education or unconscious bias training that needs to be addressed? And so before you answer that, I will also add my part of the question, which is, we have been doing some unconscious bias training as well so far. And do you think that what's been done has been effective?
Great question. Had the same thought as you were reading it to me. So I think, so to go back to that incident, that training did not exist at that time. So that was definitely not something that institution was doing. I personally do not feel that the current level of training really addresses the issue head on. I think that it's a great start, and I think that there are a lot more conversations to have, but I don't know that, number one, there are enough of us being people who are marginalized in healthcare consistently being part of that conversation on a national level. But I also don't think that it is necessarily addressing the right issues. For example, again, in that situation, the assumption was that because this child was, at least on the surface, quiet, that she was not in pain. However, anyone, and even non-medical people, could look at her arm and tell that she was. And so I think that there was more to that. And it's hard to have that conversation in real time, but I do think it's very, very worthwhile to have these conversations up front about how they can ultimately impact outcomes. I think all doctors connect to that, but I don't think we all connect to those cultural biases in real time.
I'd like to add to that as well too. There are things that are starting to be done, or rather the conversations that's starting to have. There was this series a while back that was called Social Determinants of Health. And that introduced a lot of the different issues regarding racism, regarding cultural biases that are affecting our health. And then additionally, you'll find that in a lot of different medical schools, that is starting to become part of the curriculum. Now, these are good things, and there's definitely merit to it. But like Dr. Tisdale was saying, the real-time situations that come up from, okay, all right, I learned this in the classroom. It's like it goes out of your brain whenever you're in the actual real life situation. So there's definitely gains that we need to make in regards to how do we address this in real time. But I will say that what they're doing and what they're starting to do is good, and that is bringing attention to something that is actually detrimental to our health. There's another study in a lot of pediatric clinics that I've kind of looked into. They're starting to incorporate these ACEs, so they're adverse childhood events. And so the things that children encounter in regards to family stresses, racism, all of this stuff has an implication, and it has an effect on how your health outcome is as an adult and even as a teenager. So we're starting to make improvements in these areas, but unfortunately, it's like there's so much that needs to be done. So we all, in all of the different spheres, from the healthcare professionals to the governing bodies, we all need to push, because we're gaining momentum, but we really need to all gather in all of the different areas to move forward with this information and make sure that we're plugging all of those different holes, because there's holes everywhere, from the consumer to the parents, to the system, to the government, to the product. Somebody mentioned something about medicine. So there's a lot of these different deals when we're dealing with marketing. Is this for me? Well, I don't see myself portrayed on this commercial. So is this for me? Did that study include me? And while there's sometimes the answer is no, it's still something that we need to start addressing so that we can fill those holes, and so that we can get the momentum that we need to push this mistrust out into where it's a quiet quiet whisper.
Absolutely. And I think the other thing too is, so I'm piggybacking on what you're saying, also looking at one of the questions, which is, I think the key too is really listening to patients. So like you said, it's going to be an interdisciplinary approach to how we fix this. But I think the answer, and this is for those in the audience who are, looking to become healthcare leaders and administrators, is just a bunch of us can't just sit in a room and talk to each other either, right? I think that is also the problem. We need to talk more and sorry, not talk more, let patients talk more, and we need to listen more to what they actually want and need, because what we may think they want and need, they don't. I will tell you, as a previous practice owner who, did all these things that we were going to offer at the clinic, and they came in and they wanted 9 other things that we weren't even offering, and all the stuff we put all the time into, they were like, oh, that's not important, right? So and that's me feet on the ground, right? So you just don't know. And the other thing that I didn't get to say earlier too is that, remember, there's not one experience of anything. There's no one Black experience. There's no one Latinx experience. There's no one Asian experience, right? And I know we all know this, but then we forget it when it comes time to sit down and to strategize that, just because someone is African American doesn't mean that they're having the same experience as the person literally sitting next to them. So the only way to actually solve this is to talk to the people that we want to help, and we cannot make assumptions. And so there was the last question that I saw from Jasmine that said, she has, there's family and friends who don't trust prescription medication, prefer to not take it and solve their problems in more natural ways. Some that have not been proven to be effective. What do we do? And I would like to know what you guys think as well. I will say that, again, I think the listening is a big part. I think that there are some physicians that are quick to go, oh, that doesn't work, and maybe not ask about the cultural roots and the cultural beliefs, or even the religious beliefs sometimes, in what that substance, herb, food, whatever will do for that patient, and they instantly just shoot it down. But when you do that, the person's not listening to you anymore, right? So I think the first step is like, acknowledge, like, meet people where they are. First seek to understand why they don't want to take the prescription medication, because sometimes people say that and we assume that it's a hard no, and it's something so simple like, well, I don't want to walk into the pharmacy, and you can literally solve their problem. Like, there's so much that goes on with assumptions until you ask them what the issue is, and you go, oh, that's what you're worried about? Oh, that's not even a side effect of that medication. Oh, okay, then I'm good, right? So I think there needs to be a lot more communication. Again, on the patient side, I think patients should speak up and share those things, like share why you're asking the question. So you could say, hey, what other things could I do? I don't really want to take this medication because, and that way you're giving the doctor or the healthcare provider as much information that they can work with as possible, instead of just asking the question and they don't know why, and maybe they make the wrong assumption. I think communication is the key. And like I said, I'm not taking all the responsibility off of physicians, but given what we've talked about in this hour, there's a lot of work that needs to be done. So what you can do for yourself is to advocate for yourself and explain the things that you're concerned about, and have those things strategically answered. I'm worried, I have a headache. How do I know this isn't a brain tumor? How do I know this isn't an aneurysm? Instead of just saying, I'm here with a headache. What do you think's going on? If there's something that you're worried about, say that and ask those questions, instead of making the doc dig them out, because not every doc is going to dig them out. And just the one other piece I will say, coming from a background of lifestyle medicine, I just became board certified a couple months ago. I'm actually not opposed to people trying to do things naturally, to be honest with you. I'm an osteopathic physician, and I'm also boarded in lifestyle medicine in addition to emergency medicine. So I'm all for it if they're actually going to do that, if they're actually going to work out, if they're actually going to change their diet appropriately, and not just do it like every other day on even days, but not odd days. I've gotten people off of their blood pressure medicines, their insulin, their metformin for diabetes, by them making the changes themselves. But if you're, but there's a middle ground, like, you have to do the work. You can't just decide today, I'm just not going to take any medicines and just expect to get better. So I embrace people who want to do things naturally, and then we have a discussion about what they can do. And then, or if there's things that absolutely don't work, but there's other natural things that work, I'm open to that discussion. I know not all physicians are, though. So I would say just understand that not all natural things are going to work right away either, because a lot of the natural things are more like changes. It may take weeks, it may take, so you may still need to take medications to bridge. And that's how I sell it to them. Like, look, let's start you on the meds. Go ahead and start working out, go ahead and start losing weight, and then we'll meet again in 30 days and see how it's going. So I don't know, Dr. Cooper, Dr. Tisdale, if you want to jump in there too.
Yeah, I actually was raised as a vegan, and my parents treated a lot of the illnesses that I had with natural medicine. So for me, when I talk to my patients, when I ask about medications, I say, what medications or what vitamins are you taking? That way they know, okay, I'm specifically asking, and sometimes I'll come up and I'll ask it again, because I think patients sometimes assume that you are not okay with that. And it's important to divulge that information, because there are interactions that vitamins and natural remedies can have with other treatments. So it's very important to be open and honest with your healthcare professional on what you're taking. You might be surprised, as with, I'm hearing already, that's something we typically do. So the culture of medicine is changing, and that we're incorporating more natural ways into treating different illnesses.
Absolutely. And as I sit here, I have an oil diffuser on my desk. But, so it's really funny. People think that we're very strictly into only Western medicine and only prescription things. And truth is that's definitely not the case. One of the things that I found to be really helpful in my practice is to ask, well, so did that help? I think Dr. Cooper brought up a great point. Medicine, supplements, vitamins. Have you tried anything for this? That way they know you're asking about everything. But I ask, has that helped? And the reason is because if they're in front of me, again, I don't take care of well patients, then that means they're interested in doing a little bit better than what that supplement may be doing for them. And it opens the conversation. It allows them to tell me when they started using it, what limits it has. Hey, it works really well, but just not long enough, or we've been using this a few days, it's just not any better. Oh, okay, so we want to make sure everything's still okay. And they're open to having that conversation. I also make it really clear to them, they don't necessarily have to stop that supplement if their child needs a prescription. Hey, if you want to continue to use your elderberry or your echinacea or your honey, along with this amoxicillin, I'm totally fine with that. This oil diffuser will stay on my desk, but I will still get my mammograms. I will still go to my well visits, and I will pray on my way to every visit, because God put doctors here. I think religion is a really important part of our culture also. So I think it is a great point to make sure that you are giving the information that we need to really help you understand all of the things that you're doing in your life that impact your health, but also really for us to understand that it's a conversation, not a shutdown or a redirection. Open the conversation. The more they tell you, the better we can help them. And I think that's an important thing for us to keep in our toolkit, is the power of communication.
I agree. And I think that if you meet with a physician and you bring those up and you do get the shutdown, because it may happen, then it's okay to change doctors. And I think, and you guys will see in the video, like one of the videos, that's actually what we talk about, is that you don't have to stay with that person. You have the right to choose, the same way you would choose, a restaurant, right? You don't like the restaurant and you want to go to a different one. If you don't like the service, you do have the power to change. You're not wedded to that one person. Even if they're your assigned person through Medicare or Medicaid, you can still change that physician or provider. So, but make a note to the next time to make that one of your questions in your first visit. Are you supportive of patients who take supplements and herbal medicines? Or you could even maybe see if you can ask that over the phone before you set up the appointment. And that way everybody's on the same page. But don't feel like you're locked in and you cannot be yourself. There's a fit for you out there. There are enough physicians out there that are open to it, that will embrace you. You just have to find those people. All right, I think we're at time, actually. Any quick last thoughts from either one of you guys, Dr. Cooper, Dr. Tisdale?
I think, you know, one of the questions that I really wanted to just leave you all with was, what can you do moving into these roles in the future? I think a lot of people are going to be healthcare professionals, and a lot of people will be professionals who work in healthcare. But I think you can still influence these outcomes. Go ahead, if you're motivated to start your own business, do so. I'm looking forward to bringing on interns this summer, people from different backgrounds that can really help us learn how to provide care to all kinds of people, not just ourselves. Make sure that you're able to, if you're one of those people that influences where the dollars go, that you're making sure you're influencing where they go and that they go to the right place. As we mentioned earlier, lots of opportunities in research for African Americans. I think the one institution that figures out how to identify and properly study the African American family and the African American patient will do very well for themselves in terms of trust. And so there are impacts and differences that you can make as an individual and as a professional. Just take that with you. Wherever your role is, there is an opportunity. Take it.
Yeah, and I'll add real quick. So the fact that all of you guys are here, that lets me know that you guys are looking to improve yourself. So you guys are people who go after knowledge. So continue to go after knowledge and affect the spheres where you are. So by you guys affecting those spheres where our voices are going to be amplified to where there is enough of a ripple to start to affect change. So I want to encourage you guys to continue to have these conversations, ask the questions, and seek out knowledge.
That is awesome. Thank you both for joining me today. And again, thank you guys for inviting us to be here, and have a great rest of your week.